Good morning, everybody. I am Megan Frazier. I am an occupational therapist and driving rehab specialist from Central Texas. I own Functional Stability and Mobility, a driving program that works with adults of all ages. So I start with 15 and 16-year-olds, and I see them up through the lifespan to 90, 95, 100-year-old clients. I've been practicing for about 18 years as an occupational therapist. I've kind of worked across different areas of practice from acute rehab to acute care, outpatient neuro, inpatient neuro, skilled nursing facilities, and then most recently within my own private practice. I am the vice president of the Association of Driver Rehab Specialists Texas chapter and the co-chair of the Texas Occupational Therapy Association's New Driving and Community Mobility Special Interest section. A little bit about myself. I love to travel. This is a picture of my family. I have a 13-year-old, almost 13-year-old daughter and almost 10-year-old son. And then my husband, Matt, he's a physical therapist with the Army. I'm originally from New Jersey. So I sometimes talk a little fast. I love the water, and which is kind of hard here in Texas. We don't have as much water or as easy access to it as we do in New Jersey, but I do love to swim and kayak and paddleboard, and that's just a little bit about me. Today, we're going to talk about driving and community mobility and why it's important for us as occupational therapists to address driving and community mobility, kind of our role in addressing driving across the lifespan, and some considerations that we need to think about when addressing driving and community mobility. Okay, so why is driving and community mobility important? It's a very underserved population within occupational therapy. There aren't very many occupational therapists that address driving at any age, especially here in Texas. It's something that traditionally has not been seen as an area of practice, but it is definitely a growing area of practice. From our client standpoint, it's huge as far as an IADL. It maximizes independence and then promotes and continues engagement within the community. It reduces depression, isolation, and then also by reducing depression and isolation, it helps kind of stave off other medical conditions that would come from being isolated within the home. Driving is really fun. It's dynamic and it is completely individualized for each client. Every time I take someone out, it is a completely different experience, and why they want to be able to continue driving is very different for each person, and their motivation is extremely different, which I think is kind of fun because every day I don't know what I'm getting into, and it makes it pretty exciting. It involves collaboration between a wide variety of professionals. I work with social workers, physical therapists, speech therapists, other OTs, neurologists. Because there are so many components that go into driving, we need to make sure that everybody is on board as well. And it's an emerging area of practice. So if you're looking to go into a practice area that does not have a lot of competition from other therapists, this is definitely one of those areas. Okay. What are today's objectives? We're going to talk about why driving is a great IADL. We're going to talk about the different ages that we work with in driving, and then we're going to identify different cognitive, physical, and social components needed to be a safe driver. We're going to talk a little bit about clinical assessments, understanding the state laws within Texas that guide our practice in this area, kind of the role of the OT generalist, the driving rehab specialist, and how those different roles play into evaluating our clients. And then I'm going to provide you guys with some resources as well. So why is it an important IADL? It's an activity. So we all know what an IADL is. And what AOTA defines driving and community mobility as is planning and moving around the community, including the use of public and private transportation. I'm going to primarily focus on the private transportation aspect of actually driving a personal vehicle, but it is important to realize that Community mobility also involves ride sharing, public transportation through a bus or a train, and knowing how to use those transportation options safely and independently. It can also fall within our scope of practice. Driving is one of the most important aspects, IADLs. It underlines all other occupations, including work, education, play, leisure, social participation, as well as most of our other IADLs, shopping, health management, money management, caregiving. So if you put it in that perspective, everything we do, especially here in Texas, is tied to being able to move around the community. We have to access medications, um, shopping, so groceries, clothing, being able to get to work, take our kids to sports practices, going to your job. Those are all tied with mobility and transportation. Why is it important to our clients? It promotes independence, freedom. Spontaneity is huge, especially for the older populations. They don't want to be tied to their house and having to wait on family members to pick them up and take them places. Status and identity. Most of us remember our first vehicle. And, picking out a new car is pretty important for most people. They want it to look a certain way, drive a certain way. Feelings of self worth. Some people just have a desire to help others and interact into their community, especially with our older adults being involved with their church or volunteer opportunities is really important. It may be the only way to get around. If they live rurally, the opportunity to use public transportation might not be available to them. So this is very important as an occupational therapist. In order to work at the top of our license, we need to incorporate driving and community mobility. It's our obligation to obtain data, assess the skills related to driving, and also manage risk relevant to driving, especially in the medically complex population and older adult population. It is important for us to address driving, even if it's just referring someone to a specialist, but to ignore driving as an IADL within an evaluation is not working at the top of our license. So why are OTs perfect for addressing this? Driving is high volume and a high risk activity. As OTs, we have unique skills to ID the deficits in performance skills that affect a person's ability to complete this IADL. We're great at completing an occupational profile through interviews and observation. We can assess impairment and safety issues with performance related to driving. And there's a professional and ethical obligation to ID and warn when safety deficits are identified. Okay. OTs, we have an ethical responsibility to know the state laws that relate to reporting driving. And if someone is at risk for an accident, we are ethically obligated to report that to the state regulation board. Okay. In Texas, what are the laws regarding driving? And who kind of oversees that? It is a little complex and a little confusing. The Texas Department of Public Safety is solely responsible in Texas for all actions taken regards to licensing. In Texas, we do not have a mandatory reporting law, but we have an ethical duty to discuss driving and report if we have a concern. We are protected if we do report. So this goes again, what is our role? So the Texas Medical Advisory Board, that is made up of 14 physicians across various practice areas. So neurologists, cardiologists, internists, primary care physicians. And they get together every 2 weeks and they review cases that have been presented to them. It can come from a therapist, it can come from another physician, it can come from a family member or a concerned person in the community. And this is the board that reviews any sort of medical concerns and makes recommendations to the DPS for any sort of license revocation or need for further assessment. Okay. For guidance on how they address any sort of medical concerns, They use the Guide for Determining Driver Limitations for the state of Texas. This is located online and it is broken down from different medical conditions. So, for instance, if you were concerned, you're working with a client who's maybe had a stroke and you wanted to know whether or not they fall within those parameters to be able to return to driving, this is the document that you would access. So, from an OT practice framework, client factors needed for driving. One, we need to look at an occupational profile, client report. So that's the client telling you why they want to drive, why it's important to them, places that they need to go, any problems they may have had in the past, any concerns they have. You need to look at their environment. You know, city driving in, say, Austin or Dallas is very different than rural driving. And the demands for that environment changes, and it may impact how they drive or how long they can drive. Context, and then client goals. Some clients just want to be able to go to work and the grocery store and back home again. Other clients, they work and they travel frequently, so they need to be able to drive in a diverse environments. So within the OT practice framework, some client factors that you need to consider are vision, so visual spatial skills, speed of processing, scanning, useful field of view, peripheral vision, visual reaction. So that's being able to look at a sign, understand and decode what it says, and then respond to it. Contrast sensitivity, that is like when a deer runs out in front of you at night, can you see it? Acuity, glare recovery. If you're coming out of a tunnel and all of a sudden it was dark and now it's bright, how quickly do your eyes adjust? And visual attention. If you're driving along the road and you get tired and you stop paying attention to what's around you and you kind of get that road blindness, that's what that's referring to. Motor, these are pretty easy to understand. Range of motion. So you're looking at neck and arm, leg range of motion, hips, trunk range of motion, coordination, strength, sensation is huge, especially for lower extremity pedal confusion. Trunk stability, if you have someone with a spinal cord injury, can they maintain their balance when going around a curve? Muscle tone, endurance, that is really important for clients with multiple sclerosis. They might get very fatigued after driving for a while, especially if there's any sort of traffic. And then gait, how do they access the vehicle from their home? Cognition is huge. Attention and divided attention, how many pieces of information can they juggle at any given time? Concentration, speed of processing, insight and judgment, are they making good decisions? Mental flexibility, memory, can they get home when they go to the grocery store? Do they know how to get to the grocery store? If there is a detour, can they figure out how to get around the detour? Ability to anticipate, looking at the cars around them and thinking about what they may or may not do. Orientation and problem solving. Emotion is big, especially for our young teens with autism. Regulation, insight, lability. And then, of course, values and beliefs, reasons for driving, their goals. If it's an older adult, driving retirement and how no longer driving may affect them. And then, of course, family influence and support level is big. If it's an older adult and we're telling them they can no longer drive, do they have someone to support them to get them to their appointments and grocery shopping? And on the flip side, if it's a teenager, is their family there to help them learn? Because a driving rehab specialist is expensive and we're only around for a certain period of time. So they're going to need that family support to help practice when we are not there. And then, of course, skin integrity. I'm going to briefly go over this. This is important in that thinking about how driving is done. It's called the Michon's model of driving behavior. There's the operational, the tactile, and the strategic. This is a great way to explain to driving for someone who's been driving for a long time and maybe has had a stroke or a mild cognitive impairment. And they're like, well, I've been driving since I was 15. Why can't I drive anymore? Well, they still have operational skills. They can turn the car on, they can steer, they can put on the wipers, they can put on the turn signal, but it's these next two levels that they may be lacking. The Tactical is being able to get on the road and actually complete maneuvers. They can complete a right turn, they can complete a left turn, a lane change. Usually for especially our mild cognitive impairment and dementia clients, strategic and is where they kind of start to lack. And this is where you really see their driving skills um, have impairments, especially with that dementia, mild cognitive impairment, Parkinson's disease. It's the ability to wayfind, understand what's going on around you and respond to it. A great example is we see these silver alerts on the road. It's because these older adults have lost that strategic component of thinking and driving. They get lost, they don't know how to get back, they can't think through the processes that go along with driving, that higher level of thinking, that executive functioning. So, which of the cognitive frame of references would this guy be? I had no idea what a 3-point turn is, so I just drove in a circle 3 times. He physically can drive, but it's that processing and reasoning that he's missing. This is a very broken down model of the spectrum of driver rehab specialists or services. I've included that as a link that I sent to your professor. And this just talks about the difference between an OT generalist, an OT driving rehab specialist, and a driving school. An OT generalist is just an OT that practices within the clinic. And they, of course, have the training to look at medical conditions and potential implications of driving. They're able to assess the cognitive, the visual, perceptual, and any sort of physical limitations that might impact performance in the vehicle, but there's no in-car training or evaluation. And they educate the clients about the role of the driving rehab specialist and bring up the idea of driving, whether it's to return to driving, start driving, or retired from driving. An OT DRS or CDRS, so a driving rehab specialist or a certified driving rehab specialist, is able to do the same skills as an OT generalist. However, they're able to integrate clinical findings and on-road performance. So there's an evaluation done in the vehicle, and the OT DRS is able to look at how those clinical deficits or markers might be impacting their ability to perform on the road. And then what is that next step? Do they need to stop driving, or is some training needed to get to remediate some of those behaviors? And then a driving school, of course, we're all familiar with a driving school. We went there when we were teenagers to get our license. The difference is there's no medical or awareness or education regarding aging conditions and how that might impact driving. They teach the skills of driving, but they don't understand how medical conditions might impact a person's ability to drive. And that's a really important distinguishing factor between an OT that addresses driving and a driving school. We're looking at their fitness to drive, the client's ability to drive safely within their given abilities. And if not, making recommendations that fit within what's going on with them medically. Okay, so the OT Drive model was put out by the American Association of the AOTA. And basically, it is a way to look at driving in really 3 basic components. They use the stoplight model, red, yellow, and green. Green is those lower risk clients, maybe a hip fracture. They can't drive for a short period of time, but there's really nothing else going on. It's somebody that you see in the clinic, you're comfortable with them continuing to drive, and you can make that recommendation pretty easily. On the other side of that is that red area. Those are those high risk clients. These are those clients that have dementia. They have dementia. They're struggling with basic ADLs. And that there's no way that they can safely get in the car and operate a vehicle. And those are the ones that, as an OT generalist, you should feel comfortable saying, hey, you're not safe to drive. Let's talk to your physician about that. The yellow area is kind of those in-between clients. There's some red flags. They do fairly well with their ADLs, but you're not quite sure if they're safe to be behind the wheel. It's also our teens with autism, ADD, ADHD that haven't really fit into a driver's ed program well, and they just need that additional training. Those yellow areas are where you want to refer to an OT driving rehab specialist. Okay, let's quickly look at some assessment tools to assess driving. To date, there's no single cognitive test that's been demonstrated the ability to accurately predict on-road ability. So basically what this says is there is no one single test you can give your clients to tell them whether or not they're safe to drive. Unfortunately, that's everybody is looking for that one thing that can tell them that they're safe to drive, but unfortunately it's just not there at this time. Although they have found that attention, visual, spatial cognition, and executive functioning greatly impacts someone's ability to drive. So when we look at assessments that we should be completing in the clinic to help guide our decision, these are some areas that we really need to be assessing. So some standard cognitive assessments, the short blessed test, the global dementia scale, the mini mental, the Montreal Cognitive Assessment, the MoCA, and then the Brave Cognitive Assessment, the BCAT. I personally use the BCAT. I like it. I think it's a good comprehensive assessment. Many of my clients have already completed the MoCA with another medical professional. So I like to use something that they haven't seen before, and not very many other medical professionals use the BCAT. These are some of the scores that you can refer back to if you so choose to use one of these assessments in the clinic. Here's a picture of the MoCA. Like I said, a lot of neurologists and primary care physicians use the MoCA, so it is something that you can easily access within a client's chart a lot of time. This is a picture of the BCAT. I like it. It is a paid tool, but it's really nice because at the end, they give you a printout with explanation of results for family and other providers. When we're looking at vision screening, we kind of talked about this before, acuity, depth perception, contrast sensitivity, use field of view, visual attention, and scanning. Some of the assessments that we use are the clock drawing test, the maze test, trails making A and B, MVPT, OT Dora, and the complex figures test. I've also started using the Beery VMI with my teens, and I find that fairly helpful as well. Here's a picture of a clock drawing. The clock drawing test is included within the BCAT, so I don't always do that separately because it is included, but it does give me some good insight, especially with my Parkinson's and my stroke patients. The maze test. Okay. Trails making A and B. It assesses memory, visual processing, visual spatial skills. This is one of the assessments that is pretty commonly used with driving rehab specialists because there is a lot of studies that have linked performance with driving. This is what it looks like. There's the A is you're connecting the dots, 1, 2, 3, 4, so on and so forth. Part B is you are alternating number and letter. So it's going to be 1 to the A to the 2, 2 to the B to the 3, 3 to the C. This is an area I would say probably 80% of my clients struggle with this. And it's really interesting because you can see some divided attention deficits, and it does a lot of times play out on the road. So here are some client samples. Okay, visual perceptual assessments, the MVPT, the visual closure subset of the MVPT-4 has been shown to correlate with driving ability. So this is the visual closure. OT Dora is a comprehensive assessment. It was put out by the AOTA. It's a battery of assessments. I actually pull out a couple of the subsets. I like the Bell's test, and there's a road rules test on there that I'll give to my clients as well. So if you ever wanted to address driving it within the clinic and wanted to find kind of a comprehensive battery, the OT Dora is a great one to start with. This is what it looks like. Other visual perceptual assessments, you can make a really simple traffic sign test for some and recognition. There's some new research coming out that if someone struggles with sign recognition, it directly correlates with their ability to pass an on-road test. Road rules testing, driving safety simulators, a Dynavision, useful field of view test, and the Drive Able screening. So motor assessments, you always want to do manual muscle test, range of motion, 30-second chair rise test, rapid pace walk, arm curl test, functional reach, and an alternating foot tap test. And these are kind of the areas where if we're looking at the OT Dora, I'm sorry, the OT Drive model, the ones written in red are those kind of red flag areas, and the yellow is, it's kind of iffy, and maybe we should get them behind the wheel. Just other tests, reaction timer, sensation is important, especially for our older adults. The BCAT self-driving assessment, there are quite a few self-assessments that you can give to your clients. Okay. Additional considerations, always consider red flags. Don't make assumptions about your clients, and don't use age alone as a red flag. And there are studies now saying that older drivers are actually safer than younger drivers. And there's some great research for teens with autism that's coming out of the Children's Hospital of Philadelphia that says that teens with autism are actually safer drivers than teens without. Um, Keys to successful client outcomes. A patient is independent with their ADLs and expresses interest in returning to driving. The clinician feels an on-road assessment is needed, and the patient demonstrates decreased executive functioning skills. These are some things you need to consider when you're looking at when to refer. So driving across the lifespan. So teens, it may be a teen with physical deficits such as cerebral palsy, spinal cord injury, spina bifida, a brachial plexus injury, some sort of amputation. Cognitive, sensory, emotional conditions. We're looking at maybe Asperger's, autism, ADD, ADHD. Attention is huge for kids with ADD. That subset of teens definitely has an increased risk of riskier behaviors, accidents, and traffic citations. Dyslexia, being able to read, interpret, and react to signs in a manner. Also, being able to do right-left discrimination for turns. Anxiety is huge for teens nowadays. It really impairs their ability to get behind the wheel and make quick decisions. There's a lot of my clients have anxiety layered on other medical conditions. So in the state of Texas, you can start to get your permit at, this is 14, but it should be 15. Things to consider: age, maturity level, comorbidities, family support, other resources, whatever their cognitive or physical needs may be. They might be able to address it at school partially through an IEP or a 504. What are their goals for employment, and is school involved, and can they assist? So things to look at when you're looking at teen drivers: their perceptual skills, being able to scan an environment, scanning for road signs and recognizing what they mean, changes in traffic signals, interpreting changes of surrounding cars. This picture here, there's a lot going on visually for a teen who has difficulty picking out details. This is a really busy thing to look at and understand. What do each of the signs mean? What are the pedestrians doing on this side of the road? What are all the other vehicles doing? What do you have to consider now that there is a streetcar? So using pictures like this and having the client tell you what they see and talk through it and talk about potential hazards is a really great place to start in the clinic. You need to look at social skills, especially with those teens with autism. How are they going to interact with other drivers, police officers, emergency vehicles. How are they going to respond if they get lost and manage any anxiety that pops up with that? Motor skills, of course, turning the wheel. If they have a hard time crossing midline, that's going to be a difficult skill for them. Being able to reach any sort of necessary controls and picking out if I need to turn on the windshield wipers because it's raining, can they distinguish between the buttons? Can they remember the sequence of turning on the windshield wiper? And of course, cognitive skills. Can they follow basic road signs? Can they judge right away? Do they know the right and left? Can they follow a map or a GPS? I would say probably 50% of the teens I put in the car initially have a hard time staying on the right side of the road and understanding vehicle placement and just the proprioception of their body and the car with in relationship to the space around them. So, how do you incorporate it into your practice? Educate families. Talk to them about the options. Is driving in the future for this teen? Is it not? What skills can you continue to work on on in the clinic? Can you refer them to a driving rehab specialist or a clinic with a simulator to help them practice? If the answer to all those questions is no, explore community transportation skills and work on those skills. Teach them how to use a bus schedule, call an Uber, interact with the people if they're calling Uber or Lyft. How do they interact with the driver? How do they know when to get off? How do they wayfind their place to wherever it is they're going once they're done using the transportation? We kind of just talked about all this. The only part that I didn't mention was modifications. If it is a teen with some sort of physical condition, what modifications are available to them? A lot of teens with cerebral palsy don't even know that they can drive. Do they need a left foot accelerator? Would hand controls work? So starting to discuss that with the teen even before they get to driving age is really important. Okay. Next, adults. So these are kind of the common things that we think about when we think about driving. CVAs, TBIs, some sort of progressive neurological condition like MS, spinal cord injuries, cancer, which then sometimes often leads into neuropathy, an amputation, falls, heart disease. What you need to consider when you're looking at these adults is any sort of impairment temporary or long term? Is it maybe a hip fracture that might be temporary, or is it an acute stroke that has impacted one side of their body and is going to be more of a long-term impairment? Always address immediate transportation needs, train caregivers, and talk about different options. So things that you need to look at, visual changes or neglect, executive functioning skills, strength, balance, sensory. It's pretty much the same across the lifespan at what you're looking at to be a safe driver. Always consider other IADLs and how either driving or the lack of driving might impact additional IADL skills. Be an advocate, help guide them to that next step. Is driving retirement appropriate, or is working with a driving rehab specialist the next step? And how do we access that driving rehab specialist? Okay. These are some common equipment that we refer for clients. The top one is a spinner knob that helps someone who maybe only has the ability to use one arm be able to turn the wheel safely. The next picture is a turn signal extender that helps someone who is only using their right arm be able to access the turn signal. The next one is a left hand control. The bottom, you'll see three pedals. That is a left foot accelerator. Then the middle one is a pedal extender that might be for someone who's older or someone of short stature. And then the last one is a right hand control by Vigel. I've included some additional videos at the end that if you guys wanted to see them in the vehicle and how they work, you'll be able to click on those through a YouTube video. Dementia and mild cognitive impairment. Really important, and it is very individualized what you will see for someone with a mild cognitive impairment. Sometimes they do great on the clinical and terrible on the road, or vice versa. So it really is important that you are patient specific when you're looking at your clients. Heart disease, there are some new research coming out that heart disease is important to consider when you're looking at driving, just because of blood flow, um, loss of consciousness. I had a client that I actually evaluated yesterday that had a MI, ended up with an anoxic episode and memory loss that impacted his ability to drive. So it is important that heart disease is also something that we consider when we look at driving safety. Syncope. So in the state of Texas, which also accounts for seizure, you are not able to drive for 6 months. Of course, stroke. A stroke can impact the ability to safely understand what's going on around you, your motor coordination, vision, insight. And that could either be a full stroke or just a small TIA. Visual field deficit is huge and must be cleared by an ophthalmologist prior to driving. And there are peripheral vision requirements within the state of Texas. Acuity is 20/40 in one eye. Parkinson's disease, researchers found the odds of failing an on-road test were more than 6 times greater for Parkinson's patients than people without Parkinson's. So Parkinson's disease, with it being progressive, many of our early stage Parkinson's patients can continue to drive. As the disease progresses, we limit their ability to drive and how they drive. So nighttime driving, driving in a lower radius or a lower demanding environment, and then eventually they do have to cease driving. Things that they're going to struggle with, of course, is the pressure applied to a brake. Depth perception is huge with Parkinson's patients. Knowing when to stop when approaching a traffic light. Parking is an area we really see deficits in because of that depth perception. Sometimes you'll see a delayed ability to make quick decisions, and that also impairs clients with Parkinson's. The other thing is medication. Many of my clients have to be very aware of their on-off cycles, but then also the fatigue that is caused because of their medications. Neuropathy, limited sensation in their feet, so that's that pedal confusion. Those clients, many of them still have their ability to cognitively drive, but they're struggling from a motor ability to drive in that because of the limited sensation. So we can sometimes move them to hand controls or a left foot accelerator if possible. Falls is a huge indicator for difficulties with driving. 40%, it increases your risk of a driving accident by 40% if you have falls. And then of course, older adults. It's really important as our population ages that driving becomes part of the evaluation and conversation when addressing older adults. 7 in 10 adults will outlive their driving abilities. So it is really important to start that conversation started early and bring it up often with our clients. They may still be able to drive, but at some point in their life, they're not going to be able to drive. And I think it's really important for OTs to have that conversation with our clients because our clients need to hear it, and they need to hear it a lot. They don't need to wait until they're no longer able to drive for the first time to hear that conversation because it's really scary and they get upset about it. So I think if we start to normalize the conversation of driving and the ability to drive as we age, and if we can't drive, what are our options? It'll help normalize that conversation and help people plan. And I think that's a really important role for occupational therapists. So older adults who give up driving are nearly twice as likely to suffer depression as those who stay behind the wheel. So it just hits home how important driving is to people's emotional health. So like I said, we need to start talking about driving and community ability early so we don't see this increase in depression when they can't drive any longer because they already have systems in place and supports in place to help them continue to access the community. Did you know that one half of Americans over the age of 65 don't have access to public transportation? So again, that just hits home that planning and planning and planning. And as OTs, that is something that we can assist with and is part of the ADLs and IADLs. And it is something that we can bill in the clinic for our clients. And I think it's a place that we can really make a big impact. So some warning signs for the older adults, being able to recognize, identify concerns during the interview. So they might say, hey, I had a little fender bender, or I got lost. I couldn't find my car. I turned down the wrong lane. They might say that they got upset while they were driving. These are all warning signs that you need to keep an eye on when you're talking and interviewing your clients. Um, This is just a definition of what driving retirement is. It's a plan that's individualized to help the older population maintain community mobility and participate in important life events. Things to consider when you're talking about driving retirement: locations, where do they need to go? When do they have to go there? Will it be reoccurring, or is it infrequent that they need to go to these places? What's available in their area? Really important. What are their finances? Do they have the ability to pay for someone, or is our finances limited? Are they on a fixed income? And then also, if it is somebody with mild cognitive impairment, how do those cognitive limitations impact their ability to access that transportation? You know, if someone's driving them to the doctor's office and it's at one of those big medical centers and they drop them off at the front door, can that client then make it to the fourth floor, down the hall, past 6 offices to know which physician's office is theirs? There's a lot more than just being behind the wheel. It's navigating through our environments and the community to access what we need to access. 6 and 10 dementia clients wander. So we all know the silver alerts. I do think that this is an area that we can also address when we're talking to our older clients, and having a plan and helping identify when we need to retire from driving so our older clients don't wander and become a silver alert. Billing and coding, some of the codes that you can use in the clinic: OT evaluation, therapeutic activity, ADL training, community re-ed. An on-the-road assessment is not covered by insurance. They do not find that it's important. I would say 90% of the programs throughout the country are private pay for on-the-road evaluations and training. Some additional resources: the AOTA, NHTSA, which is the National Highway Traffic Safety Administration, ADAD, AARP, the National Institute of Aging. All of these organizations have resources online that you can print out and give to your clients. ADAD actually has paperwork that is diagnosis specific. So you can print out something that says, for instance, Parkinson's disease and driving, and you can give it to your client and use it as a talking point to help you get through that discussion. These are the websites. If you have teens that you're really looking at, the Children's Hospital of Philadelphia is a phenomenal research, both from a resource standpoint, but then also from a research standpoint. They're doing some great research with teens with autism and ADHD. The Hartford Mature Market Excellence Program has pamphlets that you can hand out to your patients about driving. It's mostly geared towards older adults, but it's a great resource and it's free. This is what they look like. So at the back of each one of these pamphlets, there are actually activities that you can pull out and work through with your client in the clinic, which is pretty amazing. Some other resources throughout Texas: Vet Rideshare, AIDS of Central Texas, Drive a Senior. There are other organizations, but these are just a couple. Dallas My Ride, Area Agency on Aging, is a great resource as well. CARFIT, I don't know if you guys do this at your program, but CARFIT is a collaboration between AOTA, AAA, and AARP. It's developed to help improve driver safety and comfort. It's free. It takes 20 minutes. If you go through the training through AOTA, you get CEUs. And it looks at how is the steering wheel fit to you? How is the seat belt? Are your mirrors set correctly? I think it's a really great service for the community. And it's a great way for us to talk about driving in a non-threatening way and start making those connections with the community about driving and community mobility. I'm also running, this is technically for older adults, but you can modify it for teens with autism because a lot of teens who are getting into driving have never really thought about being in a car and what it means to be a driver. So this can be adapted for younger adults as well. Some foundational research is the Clinician's Guide to Assessing and Counseling Older Adults. This is a great guide. It was put out by NHTSA. It's free and it has a lot of the assessment tools that I discussed earlier on. The driving diagnosis pathway sheets, evidence-based consensus statements between AOTA and ADAD, and then here's some additional articles as well. Professional development, AOTA and ADAD, both had specialty certifications. AOTA's is currently being revised. ADAD's, it's an exam. You have to have a certain number of hours behind the wheel with clients to be able to sit for the exam, but it is a way to get certified. You can review articles, books, and research, attend conferences. Adaptive Mobility provides behind the wheel training for occupational therapists. And then it's always important to find a mentor within the program, within somewhere in the States that can help guide you because it can be overwhelming for new clinicians to come into this area of practice. Here are some resources that I have on my website if you guys are interested. I think that's it. Getting involved. There is a community of practice within AOTA for driving and community mobility. Advocacy is huge, both as a profession and within the specialty area, and talking about why OTs are perfect for driving and community mobility. You can host a CARFID event, host a We Need to Talk seminar, which is that Hartford guide. You can provide a pre-driving skills clinic, and that can be specific to any sort of diagnosis that you would want: teens, autism, Parkinson's disease, and that just helps those clients look at driving skills that they're going to need once they get on the road, or maybe it's driving skills that have been impaired by a certain diagnosis. Give a host and talk to other professionals about why OT should be addressing and how they can refer to your clinic. If you guys ever have any questions, feel free to reach out. Like I said, I have included separately a slideshow of different adaptive equipment that occupational therapists and driving rehab specialists typically recommend. There is low tech and high tech. My program specifically is low tech, so hand controls, left foot accelerator, spinner knob. There are more high tech programs out there. Chad Stromat with Stromat Rehab is amazing with the high-tech application to driving. So that would definitely be a resource if this is something that you're interested in. He does a lot with switches and car modifications, driving from the wheelchair. And that high-tech equipment is amazing for the clients that need it. So like I said, Chad Stromat would be a great resource for high-tech driving modifications. This is my contact information. You guys are more than welcome to reach out. The other thing that I put in there is kind of a day in the life of an occupational therapist driving rehab specialist. And I would love for you guys to watch it. It's about 8 minutes long. I have featured 2 of my clients, one with a stroke and one with cerebral palsy that does bioptic driving. So I would love for you guys to take a look at it. Feel free to reach out with any questions, and I hope you learned something. I know we went through it fairly quickly, but if you have any additional questions or want to go over something more thoroughly, please, please, please reach out. Thank you guys, and I'm excited for you to join the occupational therapy career and be colleagues. Have a great day.